So let's discuss the rest of our white blood cells, the rest of our, what we call our formed elements. Remember, these formed elements are basically all heavier substances like cells, like parts of cells, like platelets are not real cells themselves, but they're just little bits of cells that contains a lot of proteins, making it heavier. So those formed elements are going to be heavier than any single protein. They're going to be heavier than water. Because of that, when we centrifuge it, the formed elements then will fall to the very bottom of it, of our test tube. Now, the white blood cell's main purpose is to protect against microorganisms and remove dead cells and debris. Keep in mind, removing dead cells and debris is incredibly important. When you have, let's say, a pimple or a cellulitis, and basically they're both very similar in some ways. A pimple, cellulitis is basically you have an infection there, and now your white blood cells go to that site where you have a microbe being introduced, and those white blood cells starts killing the microbe. As they start killing the microbe, you'll have this increased space. So then you're gonna have what looks like this little white head, or if you have cellulitis, this real red inflamed area. Now, when you let it consolidate for a few days, it might kind of leak out white liquid. I know it's kind of gross. That little bit of pus is a combination of your dead white blood cells, dead microorganisms, and if they're dead, those microorganisms releases anything that's internal. That's what gives us that great smell. If you guys have ever been a CNA or gone into a room where there's somebody with an ulcer, or we just debrided some of the, like a large infection region, well, it smells terrible. Now, later on, as we talk to chapter 23, I will tell you a couple of my own personal stories about pus, and you will have your own, and some of them are going to be so inherent, so ingrained in your memory that there's nothing you can do to kind of kick it out of your memory, because it's going to be something dramatic. Now, in terms of white blood cells, remember, protection, movements, right? Amoeboid, diapetesis, and chemotaxis. Now, let's start with chemotaxis. What does that mean? Chemotaxis has that, right, root chemo in it for chemical, and then, right, it's got that suffix taxis. Taxis sounds like taxi. So what I want you to understand then is this chemical factors that allows us to bring white blood cells to the site of infection. Meaning what? Your white blood cells are going to be floating in your bloodstream. How many times will we have an infection in the bloodstream? Incredibly rare. We call that sepsis. Now, most of us hopefully will never get to sepsis, but we will have infections somewhere in our body. So your body is pretty big. How do we attract those white blood cells from your bloodstream to the area of infection? Well, we need to kind of give signals. So then those signals can attract the white blood cells to that site of infection. That's chemotaxis. Chemotaxis is how we attract, how we allow those white blood cells to go to the site of infection. Once it goes to the site of infection, the white blood cells are trapped in the capillary. Because they're trapped in the capillary, you need a way of moving it out. Let me see if there's a good picture of this. I think the picture for diapetesis is more likely seen in chapter 23. So, whoops. We'll discuss that a little bit more detail in chapter 23. For now, just understand what it means, right? Chemotaxis attracts the white blood cells to that specific site of infection. Your body has millions of miles of capillaries. So how do we get it to the proper spot? Well, we release chemical factors. We call them cytokines. And those cytokines allows us to attract those white blood cells to that area that's damaged and infected. Once you have those white blood cells go to the area where there's damage and infection, well, the white blood cells are still stuck in the blood vessel. So how do they get out of the blood vessel and go into the skin where you might have cellulitis. That's where diapetesis comes in. Diapetesis allows the white blood cell to kind of squeeze through the endothelial cells that make up your capillaries. Now, I will be using terms from last semester, and endothelial cells are basically simple squamish cells that form the capillaries. My 201 class, I make them understand sometimes the real basics, which is what? Why would you want simple squamish cells lining the capillaries? Simple. Is because one, simple means there's only one layer, so you don't have as many cells to get through when you're having oxygen diffuse out. Secondly, squamish, also very thin, right? Because they're thin and there's only one layer, there's less obstruction for oxygen, for nutrients, and in this example, for white blood cells to get through. So keep that in mind as we kind of discuss this. Then we talk about diapetesis right here. Diapetesis is how, once we've had the white blood cell move to that area of infection, it's still stuck in the cardiovascular system. So we need to get it moved out and into that source where the infection occurs. Usually it's in the subcutaneous tissue, it's in the skin, or God forbid you have coronavirus and you have a pneumonia that is secondary to corona. And what happens then is you need the white blood cells to get to the area of your lung that's getting attacked, that's getting infected, and now the white blood cells has to move out by diapetesis. By the way, we know some of the damage from the real bad damage from the lungs due to coronavirus is actually almost an overreaction by the white blood cells. And it just starts releasing all of these real strong immune chemicals, and it causes damage to the lungs. Now, sometimes the damage in the lungs can be so bad that once a person does actually get off the ventilator, they survive. I know a couple of sources have already said that they've had a 20-some-year-old patient that have gotten a lung transplant as a result of coronavirus causing massive damage in the lungs. So again, whenever you see a white blood cell, usually white blood cells are much larger than surrounding red blood cells. They have a purpley stained nucleus. If you see a nucleus that's just one big round bubble, that's a lymphocyte. If you have one that's even larger right there, but the nucleus right here is huge and kind of cut in place, that's usually a macrophage. If you see a cell that has what looks like little sausages, all right, and because of the way they are looking, it looks like you have multiple nuclei. It looks like you have a nucleus here and a nucleus here. Well, it's not two nuclei. In reality, it's just one, but the nucleus isn't round like this. It's more sausage shaped. Those are our granulocytes. So granulocytes have granules inside, and the nuclei in the nucleus in each of the cells are divided into lobes. It's not just one solid circular nucleus, in other words. So let's take a look. Again, get used to the kind of, in science, we have to be specific. Meaning what? When we talk about lymphocytes, lymphocytes are not the same as leukocytes. They sound identical, but they're not the same. Leukocytes means all of your white blood cells, all of them. Lymphocytes are more specific category. Lymphocytes only refers to our T cells and B cells. So we have to be very, very specific in using language in science, especially in anatomy, especially in medicine. So when we do have those written assignments, next week we're gonna have a test online. And part of it, the second part of it will be in a form of a written exam. Well, what's gonna happen is you have to be writing very specifically. You can't just kind of loosely say leukocytes attack immune system or something. What I want you to discuss from now on and to think about is to be as specific as possible, especially in the second semester. Now, let's talk about why we do have a slide later on about the CBC with differentials. But to understand the differential, we need to understand is the white blood cell and what are they specific for. So again, coming back here, we don't just have one group of white blood cells. Right here, they're showing a few groups, but even then, it's pretty small. Right, monocytes can be macrophages. Lymphocytes, there's T and B cells. Eosinophils, neutrophils and eosinophils and basophils, they sometimes change names. That's what we call these when it's found traveling around in our bloodstream. The weird thing is this: once a basophil goes into your nostrils, and some of us have allergic rhinitis, right? Hay fever. Well, we know basophils travels to your nose. When it does, it changes name, right? So the names can sometimes change. Some of you might have heard of a mast cell before. That's basically a basophil when we find it in certain areas of the body outside of the blood vessel. When it's found in the blood vessel, it's called a basophil. When it's found in the tissue, it's called a mast cells. Same thing here, monocytes and macrophages. You guys hopefully might have heard of some of these before. In chapter 5, in 201, there were what we call Langerhans cells. Langerhans cells were macrophages specific for the integument and the skin. Well, they're just monocytes, right? When we have those cells in the cardiovascular system, that's what we call it. When they migrate out and then seed into the skin, we call it Langerhans cells. When the monocytes migrate out of the cardiovascular system and migrate to the brain, we call it microglial cells. In other words, these are the cells' names as we find it in the bloodstream. But these are not the only names that we will see. And again, being very specific. Now let's talk about the ones that usually don't change names. That's neutrophils and eosinophils. Why do we do a CBC with differential? We do a CBC, a complete blood count, to see what your arrangement, what your numbers are for your hemoglobin, hematocrit, as well as your white blood cell. Now, I'm just going to be specific about the white blood cell now. White blood cells, very, very general. We should have 5 to 10,000 white blood cells as we do a CBC, right? That's the amount that's in circulating your bloodstream. Now, within the 5 to 10,000, if you're completely healthy, no source of infection, 60 to 70% of the white blood cells will be neutrophils. 2 to 4% only will be eosinophils. So the vast majority of your total white blood cell is caused by your neutrophils. Now, if I do a CBC with diff and I see your neutrophil levels, instead of being 60%, 70%, it's down to 50%, and your total white blood cell count is 15,000. What happens is this: we know you might have an infection, number one, because your total white blood cell count is high, and that infection is probably not going to be bacterium. If it's bacterium, we'll see an increase in neutrophils. But since your neutrophil count went from 60 to 70 to about 55, 50%, well, we know that neutrophils attack bacterium, and now we have a lower number. It's not going to be bacterium that's causing your infection, right? It can be a virus, it can be worms, and other types of parasites. Now, why is that important? It's important because I know at that point your neutrophil count is low, while your total white blood cell count is high. We know you have infection, and it's most likely not caused by a bacterium. So antibiotics will not be used at that point. So just a simplification of what we do with the CBC, right? Neutrophils, phagocytosed bacterium, also phagocytosis antibody antigen complexes, and other foreign matter. This is the big one right there, the bacterium. Now, phagocytosis means engulfing and destroying. Eosinophils leave circulation and enters tissues during the inflammatory response. Are prevalent in allergic reactions. So we do see this in asthma. We do see this increased number in anaphylactic reactions as well. Most likely we see it is when you have some kind of parasitic infection, including tapeworm, flukes, pinworms, hookworms, right? Now in America, we seldom see these worms, but every now and then we do see them from people in the southern regions of, right, the southern regions of the US states. Again, they're just showing us what it looks like. The last one, basophils, least common, right? Leave circulation and migrate to tissues. They play a role in both inflammatory response and allergic response. I want you to highlight these two regions right here. They produce histamine and heparin. Now, what I want you to understand about basophils is that if you take a look at the other two, their main purposes is to destroy selective microbes. Neutrophils hopefully destroys bacteria. Eosinophils destroys worms and parasites, hopefully amoebas as well. Basophils is indirect. It doesn't destroy anything directly. What it does do is it promotes an inflammatory response. And when you have an inflammatory response, it's important because you have the release of histamine and heparin. You guys, some of you might have heard of heparin. Heparin is an anticoagulant. Now, keep in mind, when we have even the cleanest kind of a cut, let's say, you are doing surgery and they're doing clean and sterile techniques for everything. We autoclave and make sure that the scalpel we use is sharp and has no microbes in it. We wash the skin, we rinse it with betadine. So then hopefully there's less bacterium also on the person's skin at the incision point. If some of you guys have ever seen nurses and doctors and surg tech people kind of scrub in, I remember scrubbing in, right? It took me about 10 minutes to wash my hands and to wash my fingertips. And then I have to put gloves on a certain way. My hands, as we were scrubbing in, I cannot have my hands facing downwards. If my hands are down, I'd have to re-scrub everything and rewash. Well, what happened was I had everything in when I was a fourth year, and actually a third year surgical student, right? So I had sterile technique. Even putting gloves on is an art form in sterile techniques. You don't put it on the normal way that you imagine putting gloves on. You have a technique to put on gloves. Also that you don't break sterility. Well, right when I put it on, everything, I already put my gown on. Again, with your gown even, you have to have somebody help you usually. So then you can put your gown on without touching anything that is non-sterile. So once you rub everything, scrub everything out, you have your sterile uniform on, everything's ready to go. If you were like me and wore glasses, at that point, my glasses falling down and I push with my finger without thinking, right? Push my glasses up. Immediately, I got yelled at to leave and re-scrub in, right? So we do all this for sterile technique to prevent infections, yet people still get infections. And it's not like it's very rare. It's pretty common, or even better yet, it's not uncommon for people to have infections at the site of cut. Why? It's not because there is actual microbes on us, because we're going to be all gloved up. It's not like they have microbes on the scalpel. What we're doing when we're cutting, no matter how sharp the scalpel, we're pushing a little bit of the patient's skin deep into the subcutaneous tissue. And no matter how clean we try to make that area where we're cutting, it will never get rid of all of the bacteria. So just by cutting with the scalpel, you're introducing microbes, right? So once you introduce the microbes, we need to make sure, right, that your body can counter those microbes. In order to do that, you want to make sure, number one, when you get a cut, you don't bleed out. So you have a coagulation cascade in that area where you have damage. So then you can clot and not bleed out. At the same time, what happens if you completely form a clot? If you completely form a clot, how are you going to bring white blood cells to that site of injury? Because there's a complete roadblock at that point. And there's a roadblock, there's a big clot in your blood vessel. You can't bring white blood cells to the site of injury. So then you can attack the microbes, and you can't bring nutrients to that source of injury so you can heal and repair. That's where histamine comes in. That's where heparin comes in. Heparin allows our clot to become smaller. So then we can localize it. So then there's room for white blood cells to travel to the site. Histamine vasodilates the blood vessel, making sure that the clot doesn't just overwhelm and form this massive roadblock. There's a little bit of space that allows white blood cells to go past that site of injury, so then you can have them go to where you have the incision and actually attack the microbes. So what the basophils do is, in the background, allow more travel of the white blood cells to the site of injury. Lymphocytes produce in red bone marrow, then migrates to lymphatic tissue, and then proliferates. You ever wonder why T cells are called T cells and B cells are called B cells? B cells are formed in the bone marrow. So B for bone marrow. They also mature in the bone marrow. T cells are formed in the thymus, the other lymphatic tissue. So in the thymus, T for thymus, T for T cells or thymic cells. Now these are more specific. Where we're going to look at neutrophils. Neutrophils find a bacterium that's invaded your body. It doesn't matter if the bacterium is strep, staph, right? Doesn't matter if it's mycobacterium. Doesn't matter what the microbe is. Doesn't matter what the bacterium is. The neutrophil is going to go to that site and hopefully destroy it. There is no immune recognition for the specific species of bacterium. There's no immune memory as well. T and B cells, they're more specialized. They will only recognize specific bacterium or viruses. Now, they're the ones that allows us to have immune memory. When you get a vaccination, these are the cells we're trying to activate and form memory cells from. So then you can have hopefully some transient, at least some transient protection. Monocytes remain in circulation for 3 days, leave circulation and become macrophages. They're phagocytic cells. They can break down antigens, and also once broken down, those antigens can then be presented to our lymphocytes for recognition. Remember, lymphocytes allows us to recognize the form specific immune memory cells. Well, how do we recognize it? Well, what happens is it can't recognize, let's say you have a virus. Even if the virus is recognized by a T cell right next to it, the T cell has a receptor that matches the virus. And that's what we mean by, recognition. Remember, these cells don't have eyes or ears. So when we talk about communication, when we talk about recognition, the lymphocytes, only way they can recognize anything is through a physical interaction, meaning that their receptor must somehow match what is being invading us. So once there is a match between a T cell receptor and parts of the virus presenting, well, what happens is you think that would be enough, right? There's recognition. Your receptor matches what's found on the virus. In reality, it's not that easy. In order for T cells to activate, the virus must first be, phagocytosed by a monocyte or macrophage. Then the virus is destroyed. As it's destroyed, now we're going to put parts of the virus on to the plasma membrane of these macrophages. That's what I mean by presenting it, right? Presenting it means that you're presenting the different parts of the virus, And now those different parts of the virus can be recognized by our T and B cells. So monocytes' main purpose, swallow up, kill a virus, but that's not it. That's not the only thing it does. Once it kills a virus, it's going to break it down, and then it's going to display parts of the virus for your lymphocytes to recognize. If it recognizes it, boom, perfect. Means that our lymphocytes can kill what's infecting us. Keep in mind, there's some overriding mechanisms, right, that I want you to always kind of think about. One is our body hates to waste energy. So why would we want to activate all of our T cells, all of our B cells, especially if a lot of them don't recognize what's invading us? We wouldn't want to because it wastes too much energy. So we want to find a way to specifically activate only those T and B cells that recognizes what's kind of invading us at that moment. It allows us to have a very targeted T and B cell population that becomes active. So then you can increase the numbers of only those cells. And once you're done and you've kind of cleared the microbe, those T and B cells just go back in reserve, right? You don't waste too much energy activating other cells that might not help. Platelets, cell fragments that are pinched off from megakaryocytes in the red bone marrow. So these are the ones that are not true cells. They're cell fragments. Now the megakaryocytes are only found in the red bone marrow, and when you need more platelets, those platelets will then come from these huge cells, and little bits of these large cells are pinched off in the bone marrow, introduced into the capillaries there, and then brought into your cardiovascular system. Now, they're important in that they prevent blood loss. They allow us to form an initial platelet plug, which then activates a series of cascades that promotes forming clotting. Now, you're probably wondering, why are these words, they sound almost identical, right? Some of these wording sounds identical, but they're really not. One, platelet plug, clot. What's the difference? We're gonna see a platelet plug is just an initial kind of stopgap. It's there, it's too big, it can dislodge more easily, and when it dislodges, it can become a emboli. So what we want to do is strengthen that plug, kind of throw a netting over it so then it doesn't dislodge. As it doesn't dislodge, you can pull the netting, making it even smaller. That's what a clot is. Kind of something more focal and stronger. Right? They're just showing us the huge megakaryocyte cells in the red bone marrow, and these little chunks right here. These are all platelets right here. These are all platelets. Now, there's a big range in the platelets. Remember, in terms of your formed elements, 99% of it is going to be red blood cells, right? So we're talking about millions and millions of red blood cells. But in terms of white blood cells, 5 to 10,000. In terms of platelets, usually we have a big range, 250,000 platelets to 400,000 platelets. That's part of our normal span of platelet population. Now, let's think about hemostasis. When I was younger, and every year I mention this, it keeps getting longer and longer. So when I was in high school, and I was a wrestler in high school, I had braces. If you've ever accidentally hit your mouth before, right, and then you feel your lip start to swell up, that was like my life for 3-4 months when I was wrestling. The reason why is simple. If you see somebody with braces in wrestling, you just get hit in the lip over and over again. So I had like a swollen lip for 3 months. Now, when you've ever had a swollen lip, what happens? Or whenever you get a cut on your fingertip. When you get a cut, doesn't it feel like there's pulsing in that cut? Almost like you can feel the heart kind of beating out of that area where you got damage, right? That's what we call a vascular spasm. That's a first, whoops, the vascular spasm that we're trying to activate is the very first step in hemostasis or forming a coagulation. So you get a cut in your finger, you get a cut in your lip. The lip is one of those that's pretty dramatic, right? You can see it really swell up. But when you get a cut on your finger, we see the same thing. You get the cut, and as a little bit of blood leaks out, your body starts to undergo vasospasms and vascular spasms. So then you can constrict the blood vessel there. As you constrict the blood vessel, you'll hopefully decrease the size of the capillary and lose less blood. In the process, you're really constricting the blood vessel, and you can feel the spasms. That spasm is a pulsation we feel. That's a vascular spasm. That's not enough though, right? The vascular spasm allows you to decrease blood loss, but we need to also form an initial platelet plug. Now, the vascular spasm is caused by vasoconstriction of damaged blood vessels. In smaller vessels, you can actually occlude them and completely shut them down. They're caused by a series of chemicals, immune hormones, I call them, right? Sometimes called cytokines. Some of you guys might have heard of cytokine storm. Well, cytokines are usually pretty helpful in a given range, right? Now, one of the cytokines is called thromboxane. Then, if you've ever had somebody with asthma, you might have heard of prostaglandins and leukotrienes. Those are all types of immune hormones. Now, thromboxanes are from platelets and endothelin from damaged endothelial cells. What do I mean? Let's take a look at this picture. This is a picture of a damaged blood vessel. How do we know it's damaged? Because normally you'll have this being continuous. What happens? You damage a blood vessel, now you're going to start to close up the blood vessel a little bit. Now, there's that balance, right? If you completely close a blood vessel, what happens? White blood cells can't get through. Red blood cells can't get through. Nutrients can't get through if you completely close it up. So that's not good either. You don't want total occlusion. What you want is a blood vessel to be small enough that then a clot can be formed, spanning that gap. That clot that's formed then will then eventually through cascades, right? We form a netting over it. So then it makes that clot stronger, more attached. So then it doesn't dislodge and become an emboli. So first step, once we get a clot, which they don't show here, the first step is to minimize the blood loss by causing the vessel that's damaged to constrict. We don't want total occlusion, because if we have total occlusion, nothing gets through. Nothing gets through, nothing gets repaired, no white blood cells are there to kill off microbes. So we want, that's where the basophils come in. We want a little bit of room left in the blood vessel. So then we can continue blood flow, just at a lesser amount. What happens then? Well, we have that vasospasm. Now, keep in mind, normally in an unbroken blood vessel, we have simple squamish epithelial cells. So pretend this is complete. You can imagine there's a couple more simple squamish and epithelial cells. Those epithelial cells, when we find it in the capillary, when we find it in our blood vessel, they change names. They're called endothelial cells, but they're the same cell, right? Keep that in mind, right? We just have a different name, and we've been very specific by calling them endothelial cells. Now, those endothelial cells are nice and smooth. When we have a complete system of endothelial cells, when we have an undamaged vessel, what happens? Blood, as it goes through this area and is completely healthy, right? Blood will just push right through. It will not get sticky. It will just move quickly through that area. right? Now, what happens though when you damage a blood vessel? When you damage a blood vessel, let's say you get a small cut. You cut all the way through your skin into the integument, right? It doesn't even have to go through the integument. As long as it goes into the dermis, that's enough. As you go into the dermis, that cut, you take out some of the capillaries. The capillaries then starts to bleed out. Now, at that point, you will start to vasospasm to limit the blood loss. That's not enough. So what happens? Well, as we damage the capillary, these endothelial cells that made my blood vessel nice and smooth, that allow blood to course all the way through uninterrupted, to move fast from one site to the next. Well, now those cells died. As they die, the collagen that was holding them together starts to leak out, and some parts of it starts to extend into the capillary, into the blood vessel. That's the first trigger. Keep in mind, blood contains those platelets, and those platelets are not active until there is a signal. This is a first signal. And the signal is that the endothelial cells forming the blood vessel has started to die. And now collagen fibers that was maintaining the basement membrane of the capillary, well, before those collagen fibers were deep, right? And because they were deep and the endothelial cells was above it, blood just slides right through. But now the endothelial cells have died off because of our cut. The collagen starts sticking out. As it starts sticking out, it causes your platelets to attach to that area. As the platelet starts to attach to the collagen, it starts to then form an initial platelet plug. And that's what we see here. This initial platelet plug is caused by the collagen fibers that are deep to your cardiovascular system, deep to the blood vessels, right? The collagen sticks out slightly, causing the platelets to activate. The platelets then attaches to the collagen, forming an initial platelet plug. The initial platelet plug is weak. It's there, it can dislodge, and it's not a very good endpoint. In other words, this would not be what we want as a final product. So then to actually firm it up, to throw a netting over it, to strengthen it, and to make sure it doesn't dislodge, we're going to throw netting over it. That's what the coagulation pathway is for. So again, first step, vascular spasm caused by thromboxanes. Second step, right? So the thromboxanes are going to be released from these cells and the cells that have actually died off. As they're released and now the collagen fibers stick out, you're going to have the platelets. Remember, these platelets are already found in our cardiovascular system. They're already found in your bloodstream. They're already coursing through the capillaries. But as long as the capillary is undamaged, they go right through without being sticky. As soon as there is damage, the endothelial cells die, the collagen fibers stick out now, and it activates the platelets. And the platelets starts to stick to the collagen. Initially, it allows us to form our platelet plug, which is a good stopgap, but it's only a stopgap. Why? It's because it's not strong enough and it's not going to be attached enough, so then you can't get it dislodged. So the last step right here is coagulation. So there's 3 steps in hemostasis, which is preventing further blood loss. So last step is we already have this initial platelet plug. That's there, but it's weak and it can detach really easily. So what we need to do then is then throw some kind of netting over it. this is a coagulation pathway. Now, the whole purpose of coagulation is to activate these threads called fibrin. This is going to be gross, so I will, just a warning. But how many of you guys have gotten a cut or a big scrape on your arm or knees? You put a Band-Aid on it. Afterwards, when you take the Band-Aid out, you see that little stringy thing coming from the Band-Aid, right? Most people think that stringy thing from the Band-Aid is due to the cotton on the inside of the Band-Aid. Well, remember, you have a little bit of plastic on the covering that cotton. So the stringy thing that we kind of move up when we remove a Band-Aid after a couple days, the stringy thing is actually fibrin threads, right? So what we're seeing is actually fibrin, and it's a good sign. It's a sign that you have formed a clot there. Now, in terms of stages, there's a lot of factors. There's 12 different factors. And what we're going to see is that for the most part, it goes in descending order, right? These coagulation factors are going to be found in your plasma. They circulate inactive until tissues are damaged, until those collagen fibers start to activate them. Damaged tissues and platelets produces chemicals that also begins activation of these factors. There's two pathways. One is called the extrinsic pathway. The other pathway is called the intrinsic pathway. And we'll talk about the differences in a second. The result is that the two pathways actually meet up. As they meet up, we're going to form a blood clot. And the blood clot allows us to form a netting over our clot. That netting is made out of fibrin, right? Fibrin fibers trap red blood cells, platelets, fluid, strengthens that clot so then it doesn't dislodge. Because remember, it doesn't matter how good your blood clot is. If it dislodges, it's going to become incredibly bad, right? We call it an emboli then. And you have a dislodged thrombus and becomes an emboli, you're going to have it go in bad places, usually in the lungs. In some people, it can actually cause a stroke. So let's take a look, right? 13 different factors. And this is the reason why I have it as part of your quiz. So then you can have your notes there. Now, for the test, the questions I would ask versus on the quiz would be very different. Like for chapter 19, right, specific chapter 19, I wouldn't ask like which factor activates which in a test. I would ask, what is the difference between the intrinsic pathway and the extrinsic pathway? That kind of bigger picture stuff, all right? So let's talk about the extrinsic pathway first. This is caused by damage to the blood vessel. As the cells that make up your blood vessel starts to die off, they're going to release thromboplastin. As thromboplastin is released, thromboplastin, right, is going to combine with one of your clotting factors, factor 7. And in the presence of calcium, they form a complex right here. That complex then activates factor 10. That's an extrinsic pathway. It's extrinsic to the actual blood vessel. It's extrinsic to our clotting and to our platelets. So the intrinsic pathway is going to be caused by the platelets themselves, right? Platelets makes contact with collagen on the damaged blood vessel, like we saw before. Now, in an undamaged vessel, should we make contact with collagen? No, because there's endothelial cells above it, right? So if you have an unbroken, undamaged blood vessel, the endothelial cells actually cover the collagen. And because of that, you shouldn't make contact with collagen. So the only time you should make contact with collagen is if those cells have died off, those endothelial cells. And now collagen kind of comes upwards a little bit. Now what happens? The actual platelets bind to the collagen and activate factor 12. Factor 12 activates factor 11. Factor 11, along with calcium, activates factor 9. Right? So it kind of goes in descending order, 12, 11, and then we skip 10, but we go to 9 instead. Right? 9, then along with another factor, this one's important, factor 8 right here. We'll talk about why factor 8 is so important in a second. Right? Factor 10, right, will be activated. Sorry, factor 10 will be activated from the intrinsic pathway by factor 8 activation with factor 9. So when factor 8 and 9 are able to combine, then we can activate factor 10 from the intrinsic pathway. Now you know why I want it on your quiz, not your test, right? Again, descending order, right? Intrinsic pathway. For the test, understand what causes it. Right? What causes it is our platelets now making contact with collagen. It's a sign that there's damage. So now what happens is that those platelets start to become sticky and they start activating the intrinsic pathway, right? They are going to combine and activate factor 12. Factor 12 is going to activate factor 11. Factor 11 is going to activate factor 9 with calcium involvement. Factor 9 and factor 8 will then activate factor 10, again, with calcium involvement. Notice, factor 10 is the meeting point, right? Factor 10 is a meeting point right here. Once factor 10 gets activated, then is going to activate prothrombin to thrombin by activating the enzyme prothrombinase. Thrombin then is going to be the last step. Thrombin is going to activate fibrinogen from fibrin, is going to activate fibrinogen to fibrin, again with calcium. Take a look at all these steps with calcium. Calcium is incredibly important in coagulation. The end result of clot formation is the formation of fibrin. That fibrin then is thrown, and I want you to think of netting. You throw it over the top of all the platelets that are already forming that platelet plug. Then as you form the netting and you're throwing over it, you can tighten the netting, and the netting then allows you to have a much smaller, more defined, more local, and even more importantly, a stronger type of clot. That clot now will hopefully not dislodge. Now again, let's just go through it, right? Extrinsic pathway caused by damaged endothelial cells. They release thromboplastin. Thromboplastin activates and combines with factor 7, forming a thromboplastin factor 7 complex, which then activates factor 10. Factor 10 is the meeting point of both pathways. Intrinsic pathway is intrinsic to the platelets themselves. And what happens? How do we activate it? Platelets making contact with collagen because those endothelial cells died. Now the collagen sticks out slightly. Then the platelet sticks to the collagen and activates factor 12. Factor 12 activates factor 11. Factor 11, once activated, along with calcium, activates factor 9. Factor 9 combines with factor 8 to activate factor 10, where it meets up with the extrinsic pathway. Factor 10 activates the enzyme prothrombinase. Prothrombinase then activates prothrombin to thrombin. You guys might have heard of a prothrombin time. A prothrombin time is we take out the blood and see how long it takes you for that blood to clot. Usually we're talking about, a few seconds to maybe 8-9 seconds, right? That's a normal prothrombin time, right? Thrombin activates the formation of fibrin from fibrinogen. The end result is that That's the sole purpose of all these reactions here, is to form fibrin. Once fibrins form, we can consolidate the platelet plug, strengthen it, make it even more focal, smaller, tighter, so then there's less chance of it dislodging. That's what we call a fibrin clot. By the way, and I'll give you guys a break after we're done with this last part. All right, now I said factor 8 is important right here. Factor 8 is important because this is a factor that was missing or is missing when people have hemophilia, right? Hemophilia back in the 1900s, right? Before 1940s, we knew the factor that was missing, but we didn't know a way of actually treating it. So people that were born with hemophilia before then had a very, very short lifespan. Nowadays, we can give them exogenous factor 8, right? As we give them somebody else's factor 8, we can activate the clotting cascade. Now, why do we have an issue with clotting if factor 8 is no longer there? Like, why do people with hemophilia A, why do they die from internal bleeding? It's because of this. Without factor 8, you take out this whole intrinsic pathway. So all of your platelets are basically non-functional, right? And you can't survive by the extrinsic pathway itself. That's it, right? So if you cut off this whole second pathway, you don't form enough clots for us to sustain life, right? Normally, people would live into their mid-20s, 30s, right? Up until 1700s from hemophilia. So they will have a shortened, very shortened lifespan. Now, some of you who like and enjoy history like I do, some of you might have heard of, the Tsars that were in Russia and the Russian Revolution. Now, most of you guys probably don't remember that, but the Russian Revolution was known for somebody we might have all heard about, Rasputin, right? Rasputin was this healer, and he was a healer that got invited to the Russian court because one of the sons of the king or the Tsar there had hemophilia. And they were deathly worried about him because that son, back in the day, right, the monarchs were all, just about all of them, were all males. So he was the sole male heir, and he had hemophilia. What happened? He should not survive, right, to actually take the throne. So they were desperate, and they used a healer, right? Eventually, the healer ended up causing even bigger problems, and eventually, right, the Russian Revolution occurred, and everybody died. But if you've ever heard of it, that story, the child actually had hemophilia A, and this is a factor that's missing. Right. Now, the weird thing about once we form clotting pathway and we form a blood clot is this. If we form a blood clot, we need a way to get rid and dissolve a blood clot. Because if a blood clot stays there past the time that it's required, meaning you fully heal, the blood clot has done its job, right? It's done its job to prevent blood loss. At the same time, it's small, it's strong, so then it doesn't dislodge. What happens then if you have fully healed the blood vessel? Now you still have a blood clot. Well, once you fully heal the blood vessel, you're going to have more blood flow to that area, increase pressure in that area. So if you don't get rid of the blood clot, you can dislodge what is left and turn it into an emboli. So just as soon as we make the clot, we need to get rid of it. And that's what we see here, right? So thrombin right here, the same thrombin that causes us to form fibrin, that same thrombin also activates an enzyme starting from plasminogen. Thrombin activates this enzyme to form plasmin. Plasmin then dissolves the clot. So as soon as you make that clot, the same hormone, or the same enzyme, not hormone, the same enzyme that activated fibrin also activated the protein that will destroy fibrin. So then there's hopefully a limited time span for that fibrin to work. All right, let's take a break. When we come back,